Welcome back to the deep dive. Today, we're tackling a beast. And I say that with the utmost respect.
You really do.
We're looking at one of those books that is, essentially the Bible for surgical students.
Oh, absolutely.
We are cracking open the 28th edition of Baily and Love's Short Practice of Surgery.
It is the heavyweight champion of textbooks, for sure.
Mm-hmm.
If you're a medical student, a surgical trainee, you don't just read Baily and Love, you sort of live with it.
Yeah.
It's the book propping up a monitor or acting as a doorstop when you're not, frantically revising from it.
Yeah.
It's massive.
It is massive. And honestly, just looking at the table of contents gives me palpitations.
Yeah.
But we are not trying to cover the whole doorstop today. We are zooming way in on Chapter 87, Gynaecology.
A big one.
A huge one. And before we even start, I want to lay out our mission because I don't want anyone sending us angry emails saying we missed a diagram.
Right. Let's be very, very clear on this.
We are going to take this dense, diagram-heavy chapter and translate it, make it sticky. We want to give you the mental anchors so that when you actually sit down to read the text, which, and I can't stress this enough, you absolutely must do.
Yeah.
It feels like you've already been there, like you have a framework.
Exactly. Consider this a companion piece. A ready reckoner, maybe? Or like a revision blaster?
A revision blaster, I like that.
We can't show you the intricate diagrams of the pelvic floor here in your ears, and we are certainly not just going to read the text to you.
Oh, God, no.
That would be brutal for everyone involved.
And so boring.
Incredibly boring. So instead, we're going to interpret the core concepts, the anatomy, the emergencies, the oncology.
And give you a framework to hang all those details on.
Precisely. Think of this as a skeleton. You have to go to the book to add the flesh.
And we're going to use metaphors. We've got some fictional case studies to kind of test your logic.
Yeah.
And we've built in what we're calling check-in points. So I'm warning you now, listener. I'm going to ask you questions. And if you can't answer them, you have to promise me you'll hit rewind. No cheating.
It's the honor system. But, if you cheat, you might fail your exams. So the stakes they're pretty high.
Okay, let's unpack this. We have to start with the landscape. Section 1, the terrain. Before we can talk about cutting anything or fixing anything, we have to know where we are. And Baily and Love starts with the anatomy. But it doesn't just start with, here's the uterus.
No, it goes way back. It goes back to the blueprint, to embryology.
Right.
The text reminds us that everything in the female reproductive tract comes from two main origins. You've got the Mullerian ducts and the urogenital sinus.
Okay, so pretend I skipped embryology class. What becomes what?
Well, the Mullerian ducts, they come down from the top. They sort of zip up. They fuse together to become the fallopian tubes, the uterus, the cervix, and the upper third of the vagina.
Okay, so they're coming down.
And then meeting them from below, kind of rising up like a stalagmite, is the urogenital sinus. And that forms the lower two-thirds of the vagina.
So wait, the vagina is actually made from two different construction projects meeting in the middle.
Exactly. And that junction, that's where things can go wrong. If they don't meet perfectly, or if the wall between them doesn't dissolve, that's where you get congenital anomalies.
Fascinating.
But let's get spatial. I want you to visualize the uterus itself. The book describes it as an upside-down pear. That's the classic description.
Right, I can picture that. But pears don't just float in midair. What's holding it up?
This is the part that is so crucial for understanding the surgery. Think of the uterus like a suspension bridge.
A suspension bridge.
It's suspended in the pelvis by this really complex network of ligaments. You've got the transverse cervical, the pubocervical, and the uterosacral ligaments.
So they're like the big cables on a bridge deck.
Precisely. They're condensed bands of connective tissue that keep the uterus stable.
Yeah.
And the cervix, that's the central pylon, the anchor point. Now, normally the text notes that the uterus is anteverted.
Anteverted. That means tilted forward.
Tilted forward, and it's resting comfortably just over the top of the bladder. But it's mobile. It's not, bolted down. If the bladder fills up with urine,
It pushes the uterus back.
pushes it right back.
Okay. And what if those cables, those ligaments, get weak? Or maybe there's scarring?
If the position changes, it can become retroverted, tilted backward towards the spine.
And that matters because...
Well, it matters because if you're a surgeon going in and you're maybe a bit blind to the exact position and you assume the uterus is forward when it's actually backward,
you could perforate it.
you're going straight through the back wall.
Yikes. Okay, so knowing the position is step 1. But let's talk about what Baily and Love calls the surgical spaces. I love how we frame this in our prep. It's like a city map, right?
It is absolutely a city map.
You've got your safe neighborhoods, and then you have the dangerous intersections.
And surgeons need to know this map better than a taxi driver. So let's map out the front yard. This is the space of Retzius.
The space of Retzius, it sounds very fancy. Where is it?
It's the potential space between the pubic bone, so the front of your pelvis, and the bladder. So if you put your hand on your lower belly, just above the bone, the space of Retzius is right behind that wall, but in front of the bladder.
And why is this our front yard? Who's working there?
Urogynecologists, mostly. If a woman has stress incontinence leaking when she coughs, surgeons often need to lift the neck of the bladder.
To give it support.
Exactly. And to do that, they have to enter the space of Retzius. It's usually filled with fat and veins. So you have to be careful not to cause a massive bleed, but it's the key access point for a lot of bladder surgery.
Okay, so Retzius is the front yard. What's the basement?
The basement is the Pouch of Douglas.
That sounds like a pub name. Meet me at the Pouch of Douglas.
Please don't say that on a date. The Pouch of Douglas is the lowest point in the entire pelvic cavity. It is the cul-de-sac between the back of the uterus and the front of the rectum. And because it's the absolute lowest point, gravity does its work.
So if anything leaks, blood, pus.
Exactly. If there's blood from a ruptured ovarian cyst or pus from a burst appendix or fluid from an infection, it all trickles down and pools in the Pouch of Douglas.
So if you're doing an ultrasound and you see this black pool of fluid behind the uterus,
you know something is leaking upstairs. It's a massive, massive red flag.
Got it.
Now, we need to get into a really technical high-stakes part of the map.
Okay.
The text talks about the pararectal spaces. These are the really complex intersections deeper in the pelvis right next to the rectum. Baily and Love specifically mentions two names, the Okabayashi space and the Latsko space.
Okabayashi and Latsko. They sound like a detective duo from the 1970s.
Okabayashi and Latsko. Pelvic vice.
I like it.
But they're actually spaces defined by the ureter. Imagine you're digging a tunnel deep in the pelvis. The ureter is this vital tube carrying urine from the kidneys to the bladder.
Right.
It runs right through this area. The Okabayashi space is the medial pararectal space, so closer to the middle, and the Latsko space is the lateral one, closer to the side wall.
And why do we care about these specific little pockets? Why is Baily and Love making students memorize this?
Because of the water under the bridge.
Okay, I've heard this phrase, water under the bridge. Explain it to me like I'm 5.
It's the golden rule of pelvic anatomy. The water is the ureter, the urine.
Okay.
The bridge is the uterine artery, which carries the main blood supply to the uterus. And the artery crosses over the top of the ureter.
I'm visualizing a hose pipe, the ureter, running on the ground, and a big power cable, the artery, crossing over it.
That's a perfect visualization. Now imagine you're doing a radical hysterectomy for cancer. You have to remove the uterus. To do that, you have to cut its blood supply. You have to clamp and cut that uterine artery.
But the artery is sitting right on top of the ureter.
Right on top. If you don't know exactly where the Okabayashi space is, if you don't carefully dissect and separate those layers, you clamp the artery and the ureter together.
Oh!
You tie them off, and you cut them.
Oh my God, you've just cut the tube from the kidney?
You've just destroyed the kidney's drainage. It is an absolute catastrophe.
Wow!
And it's not just the ureter. The text highlights the autonomic nerves right there, the hypogastric plexus.
Yeah.
If you go hacking around in that Okabayashi space and you damage those nerves, you might cure the cancer, but you've left the patient unable to empty their bladder or with severe sexual dysfunction.
So this anatomy isn't just naming parts, it's literally a map of landmines. One wrong move means permanent damage.
Precisely. That is why Chapter 87 spends so much time on these spaces. They are critical.
Okay, let's pause. This is our first check-in point. Listener, take a breath. I'm talking to you. Without looking at your notes, can you visualize that pelvic city map? Can you name the boundaries of the space of Retzius? Is it in front of or behind the bladder?
And where exactly is the Pouch of Douglas relative to the rectum?
If you're thinking Retzius is behind the rectum, you are completely backwards. Stop. Rewind to the city map section and get your bearings before we move on. Seriously.
Got it. Good. Because now that we know the map, we have to talk about the explosions.
Section 2, the time bombs. We're talking about early pregnancy complications and the acute abdomen. This is where things get fast and very, very scary.
The stakes here are life and death. And the biggest killer we need to talk about, the one Baily and Love really emphasizes, is ectopic pregnancy.
The text gives the stats, 11 in 1,000 pregnancies. That sounds low, but it's actually really common for something so dangerous.
It's a leading cause of maternal mortality in the first trimester.
And it's when the pregnancy implants outside the uterine cavity.
Usually in the fallopian tube. But the text lists others: ovarian, abdominal, even cesarean scar ectopics.
Well, that's the thing.
It's becoming more common because C-section rates are rising globally. The scar tissue acts like a little trap for the embryo to implant into.
Okay, let's use a case study to make this real. I want to introduce you to Sarah. Sarah is 28. She comes into the emergency room. She's missed her period, so she thinks she might be pregnant. She feels dizzy, lightheaded, and she has this weird specific pain in the tip of her shoulder.
Stop right there. That shoulder tip pain, that is a classic ominous sign.
Why? I mean, did she sleep funny? Why would a pregnancy problem hurt her shoulder?
It's referred pain. The nerves that supply the diaphragm, the phrenic nerve, they originate from the same level of the spinal cord as the nerves that supply the skin of the shoulder.
Okay.
If Sarah has a ruptured ectopic pregnancy, she's bleeding into her abdomen. That blood, when she lies down, irritates the underside of the diaphragm.
And the brain gets confused.
Her brain gets completely confused and interprets that pain signal as coming from her shoulder.
So shoulder pain in this context equals internal bleeding.
In this context, yes. If Sarah has shoulder tip pain and dizziness, she is unstable. She needs help immediately. This is a surgical emergency.
Okay, but what if we catch it earlier? What if Sarah just has a bit of tummy pain and spotting? The diagnosis can be tricky. Baily and Love mentioned something called the sliding sign.
Ah, the sliding sign. This is a brilliant little ultrasound trick. It's to distinguish a miscarriage from a cervical ectopic pregnancy.
Okay, how does that work?
So imagine you see a gestational sac down near the cervix. The question is it stuck there? Is it an ectopic? Or is it just a miscarriage that's on its way out?
Right. So what do? You
use the ultrasound probe to gently push on the cervix. If it's a miscarriage, the sac is just sitting in the canal loosely. It'll slide against the tissue when you push. It moves.
Okay.
But if it's a cervical ectopic, it is implanted into the wall. It's rooted there. It moves with the cervix. It won't slide.
That's a really cool tactile clinical nugget. No slide means danger.
Exactly.
Now let's look at treatment, because the book gives a very specific decision matrix. We don't just rush everyone to surgery anymore.
No. If the patient is stable, not like our Sarah with the shoulder pain, but stable, we have options. There's expectant management, which is basically watching and waiting.
Hoping the body just resolves it.
Right. And then there's medical management using a drug called methotrexate.
And methotrexate is a chemotherapy drug, isn't it?
It is. It works by stopping rapidly dividing cells, which is exactly what an embryo is. But you can't just give it to everyone. Baily and Love is very, very strict on the rules here.
Okay, what are the numbers? What are the criteria?
To use methotrexate, the HCC level, that's the pregnancy hormone, generally needs to be less than 5,000 IUL.
Less than 5,000?
Some guidelines say 1,500 for expectant, but for methotrexate, the ceiling is usually 5,000.
What else?
The mass itself needs to be small, less than 35 millimeters, and crucially, there can be no fetal heartbeat visible on the scan.
Okay, so if the HCG is, say, 8,000, or there's a heartbeat, methotrexate is off the table.
Correct. It's very unlikely to work, and the risk of rupture while you're waiting is just too high. You have to go to surgery.
And this brings us to the great debate in surgery. Salpingectomy versus salpingostomy.
Removing the tube versus opening the tube.
So salpingectomy is taking the whole fallopian tube out. Salpingostomy is just making a little cut, scooping the pregnancy out, and sewing it back up.
That's it.
To me, keeping the tube sounds better, right? You get to keep your parts.
You would think so.
Mm-hmm.
And for years, that was the thinking. But Baily and Love takes a pretty clear stance here. It says salpingectomy, removing the whole tube, is preferred if the other tube is healthy.
Why? That seems so aggressive.
Two big reasons. First, if you just slit it open, the salpingostomy, there's an 8% risk of leaving microscopic tissue behind. It's called persistent trophoblast.
So the pregnancy keeps growing.
Exactly, and you have to treat her again anyway. Second, and this is the bigger one, a damaged tube is a trap. If you leave that scarred tube in there, there's a much higher risk of another ectopic happening in the exact same spot next time.
So by trying to save the tube, you might actually be setting her up for a sequel.
Precisely. And the data shows that removing the bad tube, provided the other one is good, doesn't actually lower her future fertility rates compared to trying to save it. The other tube just picks up the slack.
That is fascinating. Sometimes you have to cut to cure.
Mm.
Before we leave the acute abdomen, just briefly, let's touch on ovarian torsion.
Oh, this is agony. This is when the ovary twists on its own blood supply. It's like twisting a finger until it turns purple.
And there's a visual sign for this, too.
The whirlpool sign on ultrasound. You can literally see the twisted vessels coiled around the central axis. It looks just like a whirlpool.
And the management, do we just cut the ovary out?
Not instantly. Historically, surgeons would see a black, blue, nasty-looking ovary and just remove it.
Right.
But Baily and Love emphasizes that the ovary is really resilient. The teaching now is to perform detorsion. You untwist it, and you wait. You give it a few minutes. Often the color returns. You want to save that ovary if you can, especially in young women.
Okay, check-in question 2. We just threw some really important numbers at you. I want you to tell me. What is the upper limit of HCG for using methotrexate treatment in an ectopic pregnancy, according to this text?
If you're standing there thinking, I think it was 10,000, or was there a limit? You are dangerous.
Hit rewind, the number is 5,000. And what's the other absolute contraindication?
A fetal heartbeat. If there's a heartbeat, methotrexate is a no-go.
Okay. Moving to section 3, the pain spectrum. We're moving from acute emergencies to chronic debilitating conditions. And we need to distinguish between two cousins, endometriosis and adenomyosis.
They're definitely cousins, but they behave very, very differently.
I like the metaphor we developed for this. Think of the uterus as a house.
Okay, I'm picturing the house.
Endometriosis is like weeds growing in the neighbor's garden. It's endometrial tissue, the stuff that lines the uterus, but it's found outside the uterus. It's on the ovaries, the fallopian tubes, the peritoneum, even the bowel.
Right, it's the right tissue, but in completely the wrong place.
Exactly. And adenomyosis.
Adenomyosis is termites inside the actual walls of the house. Okay. The endometrial tissue has invaded the muscle wall of the uterus itself, the myometrium. It's not outside. It's buried deep within the brickwork.
And that distinction is it's key for treatment. Let's deep dive into endometriosis first. The text describes the appearance of these lesions in a really visceral way.
It does. It uses terms like powder burn or gunshot lesions. They look like these little black puckered burns on the pink tissue of the pelvis.
Wow.
Where you get chocolate cysts on the ovary.
Chocolate cysts, that sounds deceptively delicious.
It is not. It's an endometrioma. It's a cyst filled with old, dark, thick blood that looks just like melted chocolate. If one of those bursts during surgery, it's an absolute mess.
Now, here is the paradox that Baily and Love highlights, and it's something every doctor needs to understand because it just defies logic. The amount of disease you see does not correlate with the amount of pain the patient feels.
It's baffling, but it is absolutely true. You can have a woman with what we call a frozen pelvis, where the uterus, ovaries, and bowel are all stuck together in a concrete block of scar tissue.
Oh, a total mess.
A total mess. And she might have very mild symptoms. Then you have another woman with 3 tiny spots of endometriosis the size of a pinhead, and she is in debilitating, life-ruining agony.
So you cannot ever judge the patient's pain by what you see on a laparoscopy screen.
Never. The pain is what the patient says it is.
The text also warns about surgical risks with endo, specifically when it's on the bowel.
Yeah, this is deep infiltrating endometriosis. If the weeds have grown deep into the bowel wall, you either have to shave them off or sometimes cut out a piece of the bowel.
Right.
And the text specifically warns about lesions that are low, about 5 to 8 centimeters from the anal verge.
Why that specific distance? What's so special about that spot?
That is the danger zone for anastomotic leaks. If you cut the bowel there and sew it back together, the blood supply is tricky, the tension is high. That joint is much more likely to leak. And a leak causes peritonitis. It's a huge, huge risk.
Okay, let's look at the termites adenomyosis. How do we spot that? We can't see the termites inside the wall easily with a camera, right?
A hysteroscopy, where you look inside the uterine cavity, often looks completely normal because the lining is fine. But ultrasound gives us the clues. The uterus looks boggy, it's bulky, and it's asymmetrical. One wall might be much thicker than the other.
And there's a specific sign mentioned.
Yes, the rainstorm, or fan-shaped shadowing.
Rainstorm shattering, what does that look like?
Well, the ultrasound waves hit these little pockets of fluid and tissue trapped in the muscle, and they get scattered. So it creates this streaky, vertical shadow that looks like rain falling in the distance on the screen.
Wow. But treatment for adenomyosis is tough, right? Because the disease is woven into the muscle. You can't just pluck it out like a weed.
No. With endometriosis, the weeds, you can cut them out. With adenomyosis, the termites, you'd have to destroy the entire wall to get them all. The definitive cure is a hysterectomy.
Removing the house to get rid of the termites?
Exactly. But for women who want to preserve fertility, it is a very, very difficult management challenge.
Okay. Check in question 3. We use the house metaphor. Can you explain the difference in anatomical location between endometriosis and adenomyosis? If you are fuzzy on the difference between myometrium and peritoneum, you need to listen to that section again.
Remember, termites in the wall is adeno. Weeds in the garden is endo.
All right. Section 4, the structural issues. We are talking about bleeding and fibroids.
Abnormal uterine bleeding, or AUB. The text divides the causes into structural things you can physically see, like polyps or fibroids, and non-structural, like clotting disorders or ovulation issues.
There's a specific drug mentioned here that I want to flag because it's a weird paradox. Tamoxifen.
Ah, yes, the tamoxifen trap.
So tamoxifen is a breast cancer drug. It blocks estrogen. So shouldn't it, I don't know, shrink the lining of the uterus?
You would think so.
Yeah.
It seems logical. But tamoxifen is what's called a SERM, a selective estrogen receptor modulator.
A double agent.
It is a total double agent. It acts as an anti-estrogen in the breast, which is great for breast cancer, but it acts like estrogen in the uterus.
It stimulates it.
It stimulates the uterine lining to grow. The text says it quadruples the risk of endometrial cancer after 5 years of use.
Quadruples. Wow.
So if a patient on tamoxifen has any bleeding at all, you have to investigate. You cannot ignore it.
Got it. Now let's talk fibroids. Leiomyomas. They are incredibly common benign tumors of the muscle. But like in real estate, what matters most?
Location, location, location.
Okay, walk us through the fibroid real estate.
Okay, first you have subserosal. These are on the roof of the house.
Okay.
They grow outwards into the tummy. They can get huge like the size of a cantaloupe without causing any bleeding. They just push on things, causing pressure or making you need to pee all the time. Intramural. These are in the walls. They just bulk up the uterus, make it bigger.
In the real troublemakers.
The submucosal. These are hanging inside the living room, inside the uterine cavity itself.
Right in the middle of everything.
Exactly. Even a tiny fibroid here, the size of a grape, can cause torrential bleeding because it completely disrupts the lining. And it can cause infertility because a pregnancy just can't implant on it.
So let's use another case. Maria. She's 45. She has extremely heavy periods. She's anemic. She's exhausted. She has fibroids. She wants to keep her uterus. She doesn't want a hysterectomy, but she's done having kids.
Okay.
The text discusses a procedure called UAE uterine artery embolization.
This is a really cool procedure. It's done by interventional radiologists, not gynecologists. Instead of cutting the fibroids out, you starve them.
How do you starve them?
They put a catheter into the artery in your leg, thread it all the way up to the uterine artery, and then they inject these tiny plastic particles. These particles jam up the blood vessels that are feeding the fibroids. No blood, no food. The fibroids die and shrink over time.
That sounds perfect.
Right.
No surgery, just a tiny pinprick. But is there a catch?
There is always a catch. The text mentions post-embolization syndrome.
What's that?
When all that tissue starts to die inside you, your body reacts. It hurts a lot. You get nausea, fever, severe pain for a few days. And it's not recommended if you want to get pregnant in the future, as it can affect the ovaries and the strength of the uterine wall.
So what if Maria chooses surgery? Myomectomy, removing the fibroids. There is a specific warning in Baily and Love about how we get those fibroids out, especially if we're doing keyhole surgery.
This is the morcellation warning.
Oh,
And
okay.
it changed the entire industry.
Explain morcellation.
So imagine you have a large fibroid inside the tummy, but you're operating through a tiny 1-centimeter keyhole incision. How do you get the big rock out of the small hole?
Yeah, you have to break it up.
Exactly. Surgeons used a device called a morcellator, which is essentially a spinning blade, to grind the fibroid into little strips to pull it out.
Okay. Sounds efficient. What's the problem?
The problem is that very, very rarely what you think is a fibroid isn't a fibroid. It's a sarcoma, a highly aggressive cancer. And you cannot tell the difference on an ultrasound or an MRI with 100% certainty.
Oh, no. So if you grind up a cancer?
You're spraying malignant cells all over the inside of the abdomen. You're turning a contained stage 1 cancer into a stage 4 widespread disease in seconds.
That is absolutely terrifying.
It is. Baily and Love is very clear. This is a major risk. You have to be incredibly careful. Now, surgeons use containment bags. They put the fibroid in a special bag inside the tummy before grinding it, or they just make a bigger cut to take it out whole.
Yeah.
But uncontained morcellation is largely a thing of the past.
A sobering thought indeed. Okay, moving on. Section 5, plumbing and support. Urogynecology.
This deals with two main things: incontinence, which is leaking, and prolapse, which is dropping.
Let's simplify incontinence, because patients often just say, I leak. But the mechanism matters immensely.
It matters entirely. If you treat the wrong one, you can make it much, much worse. You have two main types. First, stress incontinence, or SUI.
This is the trampoline problem.
Yes, the sphincter, the tap, is weak. When you cough, sneeze, jump on a trampoline, the pressure in the tummy rises, and the tap just can't hold it back. A little bit of urine spurts out.
Okay. And the second type?
Overactive bladder, or OAB, sometimes called urge incontinence. This
Okay.
is the key in the door problem.
Explain that one.
You know when you get home, you put the key in the front door, and suddenly you feel like you need to pee right now.
Oh, yeah. Everyone knows that feeling.
That's urge. The bladder muscle squeezes when it shouldn't.
Yeah.
It's a glitchy signal from the brain. You get a desperate urge, and you might leak before you can make it to the toilet.
So treatment. If I have a broken tap, stress pills won't fix it.
No. For stress incontinence, you need structural support. First line is always pelvic floor physio, Kegels, then surgery like a sling to support the urethra.
But for the glitchy signal, the urge.
You want to calm the bladder muscle down. You start with lifestyle changes, like cutting out caffeine. Then you can use drugs, like anticholinergics.
Yeah.
Or you can inject Botox.
Botox, like for wrinkles.
The exact same stuff. You inject it directly into the bladder muscle. It paralyzes the muscle slightly so it stops squeezing so aggressively.
Okay, check-in question 4. Let's test your logic. If you have a patient who leaks when she coughs, so stress incontinence, and you prescribe her Botox, did you do the right thing?
Absolutely not. Think about it. She has a weak tap. If you paralyze her bladder muscle with Botox, she might not be able to push urine out at all. She'll go into retention. You have to diagnose the type correctly.
We also have to mention the M word here, mesh.
Yes, Baily and Love notes this as a high vigilance area, especially in the UK. Using synthetic mesh to hold up organs for prolapse has caused severe life-changing complications for many women.
Erosion, pain.
Chronic pain, erosion into the vagina. The text emphasizes that mesh for vaginal prolapse is now largely restricted.
And speaking of prolapse, this is when the organs drop. The bladder, the rectum, or the uterus itself falling down the vagina.
The text mentions the POPQ system. Don't panic. You don't need to memorize the grid for this deep dive. Just understand the concept.
Sure.
It's a system that measures how far the organs have dropped relative to the hymen. It's just a standardized way of grading it.
And for those who don't want surgery, is there a non-surgical fix?
The pessary. Think of it as a structural shelf. It's a silicone ring or a cube that you insert into the vagina to physically hold everything up.
And it works?
It can be very effective, but it requires maintenance. The text says ring pessaries need to be changed every 3 to 6 months to prevent infection or erosion.
We are in the home stretch. Section 6, the silent threat, ovarian tumors.
This is a heavy section. Ovarian tumors can be benign or, of course, malignant.
On the benign side, we have the monster in the closet, the dermoid cyst.
These are teratomas. They come from germ cells, the cells that can become anything.
Mm-hmm.
So when you open these cysts up in the pathology lab, you find hair, skin, teeth, cartilage.
A cyst with teeth? That is pure nightmare fuel.
I've even seen thyroid tissue in one. But they're usually benign. The real fear is epithelial ovarian cancer.
It's silent killer.
It's called that because the symptoms are so vague: bloating, feeling full quickly, needing to pee more, things that are easily dismissed.
Baily and Love gives us an equation to help assess an ovarian mass, the RMI. The risk of malignancy index. I love an equation because it takes some of the guessing out of it.
It helps triage patients. The formula is RMI equals U times M times CA125.
Okay, let's break that down.
U is the ultrasound score.
Yeah.
You get points for bad features. Is it solid? Does it have multiple cysts? Is it on both sides? Is there fluid in the tummy?
Makes sense. M.
M is menopausal status.
Okay.
This is a huge multiplier. If the woman is premenopausal, M is usually 1. If she's postmenopausal, M is 3. The risk triples simply because of her age.
And CA125.
That's the blood biomarker, the tumor marker.
But I want to pause on CA125 because patients often ask for this test just to be safe. Is it a good screening tool?
No. It is a terrible screening tool for the general population. It is notoriously nonspecific.
Why? What else makes it go up?
Because CA125 goes up anytime the peritoneum, the lining of the abdomen, is irritated. So it goes up with cancer, yes, but it also goes up with endometriosis during your period, with appendicitis, with fibroids, even with pregnancy.
So if a 25-year-old woman has a slightly high CA125, it's probably not cancer.
It's probably her endometriosis, or she's just on her period. But if a 65-year-old woman have a high CA-125 and a complex mass on her scan,
Yeah.
that is highly, highly suspicious.
And briefly, staging. Ovarian cancer staging is a surgical event. You can't just do a CT scan and be done with
Yeah,
it.
you have to go in. The text lists the steps. Washings, where you take fluid samples, removing the omentum, which is the fatty apron of the gut where cancer loves to hide, removing the uterus and ovaries, and checking lymph nodes. It is a massive operation.
Phew. Okay. That was a marathon. We have traversed the pelvic floor, navigated the danger zones of surgery, managed ectopics, differentiated pain types, fixed the plumbing, and screened for tumors.
We covered a lot of ground.
Let's do a rapid-fire summary. The big 3 takeaways from Chapter 87 to keep in your pocket.
1. Ectopics. Remember the HCG threshold of 5,000 for medical management, and you have to respect the shoulder tip pain.
2. Endo versus adeno. Location. Endo is outside the weeds. Adeno is inside the muscle, the termites.
And 3. Ovarian risk. Use the RMI calculation, U times M times CA-125. And please remember that CA-125 is not specific in young women.
And here is my final provocation for you, listener. The text mentions, and it's quite sad, really, that we still don't have a perfect screening program for ovarian cancer. We have pap smears for cervical cancer, and they work wonders. We have mammograms for breast. But the ovary, it remains elusive.
It does?
Why is the biology of the ovary so difficult to monitor compared to the cervix? Is it just its location? Or is it something about the nature of the disease, how it sheds cells differently?
It's a question that researchers are still trying to crack. It's a huge challenge.
Something to mull over. Remember, this deep dive was just the skeleton. You need to go and put the flesh on the bones.
Open Baily in Love, Chapter 87. Look at the diagram of the space of Retzius. Look at the ultrasound picture of that germoid cyst.
Read the book, understand the anatomy, save a life.
Thanks for listening. We'll catch you on the next deep dive.